Dr. Seking, Dr. Martin, thank you very, very much for the invitation in this really beautiful city. Over the last 10 years, 15 years, I spent more time with my family. I didn't want to miss my children, my family. And now it's time for me to come back to the meeting, and I feel home. I feel home because I see some big star. For 20 years, I was a small doctor, and I remember the big star of the endometriosis. I'm part of you. I'm very, very proud to be here. Thank you so much for the invitation. And I need the last 10 years, not just to spend my time with my family, but to perform also surgery. And maybe I'm a little bit like Harry. I perform more surgeries than I'm writing paper. I made some paper, but I spend my time to develop the neuropelviology. And the topic today is endometriosis and the pelvic nerves. And this morning we heard the question, how to do the diagnosis of the endometriosis, and you need surgery. In my opinion, if you have a patient with endometriosis with infiltration of the vagina, you don't need surgery to make the diagnosis. You see the diagnosis in the cul-de-sac of Douglas. The second situation where, in my opinion, you don't need laparoscopy to make the diagnosis is when you have an endometriosis of the pelvic nerves, because the diagnosis is a clinical one, and you have to confirm your diagnosis with a laparoscopy. So in the pelvis, we have a lot of nerves. We have somatic nerve, we have afferent nerve, we have efferent nerve, we have visceral nerve. Afferent nerve are the information that bring all the fibers that bring the information up to the nerve. So we are speaking about inflammation, and I'm sorry, because inflammation is not painfully. Endometriosis is not painfully either. What is painfully are the nerves. If your patient feels pain, it's not because she is affected by endometriosis, but because the endometriosis affects the pelvic nerves. And the pelvic nerves brings the information of pain to the brain, and that is pain. You have the efferent fibers going down. When you have an endometriosis or another pathology of the pelvic nerve, you always have pain and dysfunction because of the nerve going down. And you have in the pelvis two kinds of nerves, the sympathetic and parasympathetic nerves, the autonomous nerve, are always affected by endometriosis. That's the reason why endometriosis is so painfully. And sometimes you have an endometriosis to the somatic nerves. The inferior hypogastric plexus on the small nerves, autonomous nerve, everywhere in the body. And we were speaking about the different location of endometriosis in the pelvis. It's very interesting. If you check the anatomy of the sympathetic nerve in the pelvis or in the entire abdomen, you will find exactly the endometriosis at the same place you will find the sympathetic nerve. And maybe not all sympathetic nerve in the pelvis. Only in women, you have the neuropeptide epsilon sympathetic nerve located in the pelvis. And these nerves are involved on the most powerful vascular growth factor in the pelvis and probably are involved in the pregnancy and in the growth of the endometriosis. So all patients affected by endometriosis have, because of the inflammation of the uterus, an irritation of the sympathetic nerve that called the inferior hypogastric plexus. And when these nerves are affected by endometriosis, the patient will have pain, visceral pain, in the entire pelvis. The patient is not able to say, I have just pain on the right side or on the left side. She will say, I have pain in the entire low abdomen, maybe a little bit more on the left, on the right, and very, very important. And that is the key of the diagnosis. When you have an affection of the sympathetic nerve, or parasympathetic nerve, the autonomous nerve, you will always have vegetative symptoms because the pelvic plexus is a vegetative nerve system. So the patient will have all these vegetative symptoms. And when you answer the question, how to make the diagnosis, you are like a criminalist. You have to check, to look your patient. You have to look your patient in details. And you will make the diagnosis before you start with the examination of the patient. When you have an irritation of the nerve, when it's an irritation of the somatic nerve, like the ischiatic nerve. The patient will develop irradiation, pain going down. When the patient have an irritation of the inferior hypoglossal plexus, the pain is going up by following the superior hypoglossal nerve and then the superior hypoglossal plexus. And that's the reason why all patients affected by endometriosis always suffer from back pain, because the nerve are following the back, so the patient will have back pain, cranial irritation. And when we have patient today, we see a young patient, 18 years old, maybe affected by endometriosis, and every month she's suffering from pain, and sometimes she's falling down in syncope. So it's easy to say, yeah, it's a small lady, she's maybe a little bit sorry, but it's what we heard about endometriosis, a little bit crazy. No, she's not. If a boxer is giving you a punch in the plexus solaris, you're knocked out. And it's exactly what the endometriosis can do with this patient. When you have really an overactivation of the sympathetic plexus and the solar plexus, the patient will fall down in syncope. And that's the patient are affected by anxiety, oppression. It's normal. It's because of the activation of the sympathetic nerve system. It's not a question of here. It's a question of here. When you have an overactivity of the sympathetic nerve, you will have diaphragm spasm. Lots of patients affected by endometriosis, even when they don't have an endometriosis of the diaphragm or of the lung, very, very seldom. She will say, during the men's bleeding, I have some difficulty to breathe. Why? Because she has an overactivity of the sympathetic nerve system. She will have diarrhea, bloating. She will have gastric pain. On the shoulder pain on the right, we all think about endometriosis of the diaphragm. But on the left, it's because of the overactivity of the sympathetic nerve system. And we were speaking about immunity in endometriosis. The sympathetic nerve system controls also the immune system. So patients affected by endometriosis have trouble of their immunity. And by the through, you can make the diagnosis when the patient is sitting in front of you during the consultation. When you have an overactivity of the sympathetic nerve system. I don't say that you can do the diagnosis of endometriosis without examination. I say you can make the diagnosis on an overactivity of the sympathetic nerve system. And the most frequent etiology in young women is endometriosis. So, vegetative symptom, you will find a dilation of the pupil. It's typically patient affected by endometriosis. Dryness of the lips on the mouth, you see that. The patient will have flushing like that. It's typical. You have a patient, pale in face. She seems to be very tired. She have anxiety. She have oppression. You will find flooding. You will find tachycardia, maybe nausea. You will see hyperhidrosis, even when the patient is coming with your office. She is pale in face. Good morning, lady, and you will feel hyperhidrosis in the hand. So you have the diagnosis after 1 minute. Just look your patient and take your time to do that. So when you have an overactivity of the sympathetic nerve, you have sympathetic nerve everywhere in the body, also in the uterus. So you will have a trouble of the motion of the uterus. Then that maybe explains the retrograde menstruation. You will have an increased risk for ectopic pregnancy because the sympathetic nerve controls the motion of the tube. The patient will have polyhypermenorrhea, dyspareunia. Apareunia because the upper part of the vagina is controlled by the sympathetic nerve, the lower part by the pudendal nerve, as well as the vulva. When the patient and the overactivity of the sympathetic nerve is typical, probably also in the city of New York, when the birth is going down, you will see that all patients are not able to empty the bladder. That's the reason when the birth is going down, you will see more bladder infection in birth people because they are not able to void the bladder properly. And you will see exactly the same in patients affected by endometriosis. if you send your patient on the toilet and you check by sonography, you will see a post-void residual volume from more or less 40 to 60%. And that explains why patients affected by endometriosis during the men's bleeding have to go quite often on the toilet. Imperiosity, polyacysuria, increased risk of bladder infection because they are not able to empty properly the bladder. Over the time, they may develop a bladder overdilation, especially if you perform a surgery before and you cut a lot of nerves. You have the same in the bowel. 60% of the patients affected by endometriosis are suffering from what we call an outlet obstipation syndrome. And gynecologists, we have to be aware that when we see such a bowel, it's something pathologic. It's an elongation of the bowel with a lot of kicking, and it will induce a lot of symptoms typical for an outlet obstipation syndrome with a lot of bloating, pain in the back, and in 30% of the patient, pain going down in the anterior face of the legs. And that is typical for this pathology, the outlet obstipation syndrome. When you perform surgery and you have a resection of the rectum, you have to keep in mind that the voiding nerve of the bladder, what we call the parasympathetic nerve, are located deep in the pelvis. The parasympathetic nerve from the left bowel up to the left fracture are coming from the sacral nerve 2, the sacral nerve root 2. That means when you perform a bowel resection and you cut all this nerve, you will induce a paraplegia of the entire left big bowel. The right is controlled by the nervus vagus. That means, suppose you had performed nice surgery, you cut all the nerve, your patient have to void the bladder with a catheter, and she's suffering from a chronic constipation. You send the patient to the general surgeon, he said, okay, let's cut a part of the bowel, it will help. No, it will not help. If you want to do a surgery and you want to help your patient, you have to perform an hemicolectomy. You have to remove all the left side, because the parasympathetic nerve is controlled by, of the left big ball is controlled from the pelvis. For more or less 10 years, I make a study. I got patient, I'm a neuropelvologist today. That means I was dealing with pacemaker and electrode. I put device on the nerve in the pelvis in order to have recovery of bladder function in patient after surgery. And I make a study in order just to check why patient after bowel surgery or after endometriosis surgery have such difficulty with the bladder. And over the last 10, 15 years, I always heard, okay, when you do surgery, you have to cut all parasympathetic nerve. The patient will develop atonia of the bladder on the rectum. But the first reason for bladder atonia is not the motor atonia of the bladder by cutting the parasympathetic nerve, but the cutting of the sympathetic nerve, the nerve of the feeling. And if you see this publication, all this data, if you perform bowel shaving, rectum shaving, discoid resection, or segmental resection, it don't make any difference. The difference between after and before the surgery in terms of bladder function is if you perform parametric resection, because the nerves are in the parametria, are not in the bowel. And the first reason for bladder atonia is the overdilation of the bladder over the time. When you perform nice surgery, you resect the sacrouterine ligament. That means you resect part of the big part of the sympathetic nerve, the feeling nerve of the bladder. That means your patient will not feel properly the time where she had to go on the toilet. So instead to go every 3-4 hours on the toilet, it will be easy if she have working life, she have kids. So if she can go maybe every 6 hours on the toilet, it make her life easy, but it will destroy her bladder. Because over 6, 7, 8 years, because of overdilation of the bladder function will decrease and the patient will be not able to void the bladder anymore. That means when you're performing radical surgery in the pelvis, surgery of the sacrouterine ligament, you have to control the post-void volume after emptying the bladder, and you have to advise your patient to go at least every 3-4 hours on the toilet, and not just 3 times per day. So now let's go to the sacral plexus and the sciatic nerve. I performed the first surgery of the sciatic nerve 2004, for a long time. And at that time, the comment were, Marc, it's nice surgery, but maybe you will see 1 or 2 cases in your life of endometriosis of the sciatic nerve. I make another choice. I didn't go further to the meeting of gynecology to present my data. I went to meeting of orthopedists, neurosurgeon, and neurologists. And I said, hi, guy, if you have a young woman, 30, something like that, suffering from a sciatic pain, we all read cyclical sciatic pain. The patient will suffer from sciatic pain every month during the men's bleeding. It's not true. When your patient is affected by endometriosis of the sciatic nerve, she will have permanent pain all the time. Maybe with increase during the men's bleeding, but she will have terrible pain, neuropathic pain, somewhere between 8 and 10. And I said to the guy, if you see such a patient, think about endometriosis. And at that time, I see from year to year, I got more and more and more patients affected by endometriosis. Here you see a patient affected by endometriosis of the femoral nerve, and the diagnosis you can do before the surgery. Patient have pain, a lot of pain. She have loss of patellar reflex. You will see a myoatrophia of the quadriceps muscle, and she will not able to walk properly. We heard before, if you have an endometriosis of the sciatic nerve, the patient have to come in your office in a wheelchair. No, the sciatic nerve is just involved in the control of the buttock and the tooth and the ankle. But the main nerve for the walking function is the femoral nerve. And so far, you don't cut completely a nerve, even if you resect 70-80% of the nerve, and you have to do that. If you resect, if you have an endometriosis of the bladder, you will resect this part of the bladder. The bowel is the same, and you have exactly to do the same with the nerve, if you want or not. I know that a nerve will have only one femoral nerve on the left and one on the right. But if when 80% of the femoral nerve has been destroyed by the endometriosis, you have to resect. Otherwise, you will have to do the next surgery 6 months later. So, and here you will see, so far, you don't resect all the nerve, and you'll see here, that is the right femoral nerve, and we remove the endometriosis. And with a lot of training, physiotherapy, and you see here, it's not a lot of rest of the femoral nerve. Here, just few millimeters. Here, I resect this part too. The nerve will recover. Never cut completely a nerve, but when you resect the nerve, the fiber you cut will use the rest of the nerve to pass over the lesion you did. So, the sciatic nerve. Sciatic nerve, I know that it's becoming more and more modern to speak about endometriosis of the sciatic nerve. We had different kind of endometriosis of the sciatic nerve. And at that point, I want to really say you have to learn how to make the diagnosis. It's not just the patient have a sciatic pain and now I have to do the surgery. We are not technicians. We have to make first a diagnosis. If you have suspicion of endometriosis of the sciatic nerve and you don't know where you have to look for the endometriosis of the sciatic nerve, maybe you will make a nice dissection of the sciatic nerve, but you will not remove the disease. So the first kind of endometriosis is endometriosis of the lower part of the sacral plexus, close to the sacral bone. It's a typical endometriosis of the parametria, deep infiltrating endometriosis, probably with infiltration of the ureter, because the ureter and the sacral nerve root has a few millimeters each from the other, just a few millimeters. And when you have an endometriosis at this place, you will have an involvement of the sacral nerve root S2, S3, and S4. S2, that means the patient will develop a sciatic pain in the inner border, dorsal aspect, inner border of the thigh, down to the tooth. Because of S3, S4, she will develop vulvodynia, perianal pain, perineal pain means a pudendal pain on the same side. And because the nerve involved in the bladder function are located in the sacral nerve root S2, S3, S4, the patient will develop an hypersensitivity of the bladder. If the endometriosis only irritated the nerves, that means the patient has to go every hours on the toilet to pee. But if the endometriosis destroys the nerve, she will have also polyacysuria, but not because of an hypersensitivity of the bladder, but because she is not able to pee. So she has high volume after voiding of the bladder, and she will develop the polyacysuria. That means when you have a patient with deep endometriosis, parametric infiltration, mostly on the left side, you see maybe that the patient have present on dilation of the ureter. You have to ask the patient, do you feel pain in the legs? Do you have pain, burning pain in the vulva, in the perineal or in the perianal area? Do you have to go every hour on the toilet? When the answer is yes, you have high suspicion of an infiltration of the sacral plexus. And we are lucky because this kind of endometriosis usually ties the nerve but don't grow inside the nerve. So usually it's not need to resect the sacral nerve root. But if you have to go there and remove the endometriosis, of course, you will cut all the plantar nerve on this side. That means the patient will be able to void the bladder from the other side. You have maybe to use a suprapubic bladder catheter, and please don't go on the other side. Otherwise, the patient will have to void the bladder using a bladder catheter. Now we are coming to the through sciatic nerve endometriosis, the supracardinal portion of the sacral plexus. That means we are above the uterine vessel, the internal vessel, and then the patient will develop the typical sciatic pain. L5 is involved in the dorsiflexion of the tooth and of the foot. S1 is typical the plantar flexion of the toe and the Achilles reflex. That means the patient affected by this endometriosis, when you have a destruction of the nerve, will be not able either to have a plantar or a dorsal flexion of the tooth. So when you have a lesion of S2, from S2 you have one very, very important nerve, is the inferior gluteal nerve. This nerve controls all the muscles, the gluteal muscle, the main gluteal muscle. That means when the patient has a lesion, destruction of S2, she will have a destruction of the inferior gluteal nerve. And while walking, she will develop the typical Trendelenburg sign. That means normally when you are walking, you will keep up the hip. This patient will be not able to keep up the hip. The hip will be down while walking. And when you have the patient of your consultation of the stool, just look. Here she had an endometriosis on the left side. What do you see? Typical myoatrophy from the gluteal muscle. And it's exactly what I said before. Neuropelviology is clinical observation. You have to make the diagnosis by open your eyes. Here, the pudendal nerve. The pudendal nerve, we have both, two. One on the left, one on the right, is involved in the control of the sphincter. But look, this patient. If I'm looking once again, I ask the patient to contract, and what do you see? The anus is going this direction. Normally, the clitoris, the vulva, and the anus are on one line. That means when you ask the patient, can you contract the anus will go up, following the midline. When the anus is going on the left side, that means you have a destruction of the pudendal nerve on the right side. There are small details, really small details. By open your eyes and you will see. Another very important point. Here, S2. You have the sacral nerve root, S2. S2 is involved in the flexion of the big toe. S3 of all toes. Here you see, is during a procedure, I'm putting electricity on S2 and S3, and I have a contraction. That means if you want just your patient, are you able to go on the top? She will say yes. Yes, that means she has preservation of the Achilles reflex. But if the patient has some trouble of the equilibrium, because she loses the function of the big tooth. The big tooth is very, very important to control the pronation of the tooth. That means the patient will have some difficulty. Make the diagnosis with the right question and just see your patient. And now I will show you sciatic nerve, because over the last few months, I got some video from colleagues that performed very, very nice dissection of the sciatic nerve and asked me, Marc, I have a problem. I know that the patient has endometriosis there. The radiologist told me, yes, there is probably endometriosis of the sciatic nerve. I made a dissection, but I didn't find the endometriosis of the sciatic nerve. And that is the point. You have to know before the surgery where you had to look for the endometriosis of the sciatic nerve. You cannot go through with your laparoscopy and you open everything just to look where is my endometriosis. You have to know that before the surgery. And let me show just 2 cases. Here, patient, typical sciatic pain, L5, so we are here in this area. Is the cranial part of the sciatic nerve, L5 and S1. So you will see patient have a loss of the Achilles reflex. You see here myoatrophy from the calf on the left side. You will make the diagnosis by looking the shoe of the patient, because the patient have a steppage gait. She have no dorsal flexion of the ankles. That means she will destroy the tip of the shoe. So you will make the diagnosis by looking the shoe. And then when you make your examination, you will find reduction of the Achilles reflex, no plantar and dorsal flexion of the ankle. You will find the typical hypoesthesia, but you will never find in endometriosis of the sciatic nerve vulvodynia, pudental pain, because we are in this area, not in this area. And then you will confirm the diagnosis by doing the laparoscopy. And today we have performed more than 300 cases of endometriosis of the sciatic nerve. So when I remember the colleague 2004, Mr. Possover, you will see 1 or 2 cases of endometriosis of the sciatic nerve in your life. No. I'm saying more and more every day. And for several months, I sent some letter to colleagues, please help me. We have a big problem. Because there are still colleagues giving hormone to treat endometriosis of the sciatic nerve. And that is a big mistake. If you give hormone to treat endometriosis of the bladder or the rectum, and you have to resect 2 centimeters instead of 1 centimeter, okay, it's not a big deal. But if you're missing an endometriosis of the sciatic nerve and you have to resect 5 millimeters from the sciatic nerve instead of 1 millimeter because you try with hormone for the 6 months, then you made a big mistake. Here you see, it's an old video. And it's like the endometriosis in the pelvis. Sometimes you found a lot of fibrotic tissue. Sometimes you found endometrioma. And here that was a patient. I found an endometrioma in the middle of the sciatic nerve. And when I made my paper here, very interesting, I had 178 cases of endometriosis. I sent more or less all patients to MRI before. The radiologist made the diagnosis of suspicion of endometriosis of the sciatic nerve in only 21 patients from 178. So if you go to the radiologist after and said, I found endometriosis, or let's show, then they will see. But before the surgery, most of them will not see. And here you see, I have to resect part of the sciatic nerve. I found chocolate fluid within the sciatic nerve. You have to do your job, but you have to be aware. When you go to this field of surgery, and in my opinion, it's not gynecology anymore, it's neuropelviology. You have to completely control the situation. You can kill the patient there, and you have to finish the procedure. Because if you try And in the middle of the procedure, you stop. For the next surgeon, it will be awful, because he will not just find endometriosis, a scar tissue from the endometriosis, but also your scar tissue. So you have only one shot if you want to do this surgery. And here you see a patient, I resect more or less 50% of the sciatic nerve. This part of the sciatic nerve is destroyed by the endometriosis. You have to resect this part. Now, I show you another endometriosis of the sciatic nerve, the same name. Patient has the same pain, sciatic pain, but she has a Trendelenburg sign. She has a deviation of the anal. She has difficulty to sit, of course. It's an Alcock canal, it's a pathology of the pudendal nerve. No. You can have also such difficulty when you have pathology of the pudendal fibers within the sciatic nerve or the sacral nerve root. And you have this myoatrophy. So, it's a typical endometriosis of the sciatic nerve. And look, here we have the sciatic nerve. We make a nice dissection, but we didn't find endometriosis. And it's exactly what happened to the two colleagues. They performed nice dissection of the sciatic nerve, didn't find the endometriosis, and said, where is the endometriosis? They didn't make the diagnosis. The patient have a problem. She have lesion of the pudendal nerve. She was not able to sit. She have a problem with the levator. She have a problem with the dorsal cutaneous femoral nerve. That's the reason why she had pain here and hypoesthesia in this area. And she had the gluteal myoatrophy. So I know that when I have this constellation of these four nerves, my problem will be not within the sciatic nerve, but below the sciatic nerve. And here it's a typical endometriosis of the sacrospinous ligament. We have to resect all part of the obturator's muscle. We will have to resect the sacrospinous ligament, and sometimes you will see some black fluid coming out. And then we will have to dissect. Here you see, that is the pudendal nerve. Here you have the dorsal nerve, the dorsal femoral cutaneous nerve. And that's the reason why this patient has this pain. So you have to make the diagnosis, what you have to do before the surgery. And in this situation, we had to resect very large nodule from the obturator's muscle, the sacrospinous ligament. Here we have the ischiorectal fossa. It's true that it's more difficult than oncological surgery. I was oncologist for 15, 20 years, and it was easy, my job. Oncologist, you have just to cut. In endometriosis, you cannot just cut. You have to spare whatever you can spare during the procedure. And sometimes we have major endometriosis, and we make a paper about 46 patients where we perform resections at more than 30 to 70% of the sciatic nerve. And here you will see that is a patient who have just a small lesion, a really small lesion of the peritoneum. And at least we found here a huge endometriosis. We had to resect part of the obturator's muscle. Here it's a psoas muscle we had to resect. You have to know where you are when you do this kind of surgery, because we are dealing with the gluteal vessels, the pudendal vessels, all these big vessels below the obturator's nerve. If you don't know properly the anatomy there, you can simply kill your patient. So in my opinion, and it was one of our talk in the last meeting in Wien before Christmas about this kind of surgery, who have to do this kind of surgery, in Europe, our answer was probably not the normal gynecologist. That is a surgery from the neuropelviologist, at least because you have to be able to do the diagnosis, the proper diagnosis, before you start with this surgery. When I'm in that step, I cannot say, here's the sciatic nerve, I'm afraid. I cannot come, please call Mr. Possover. Mr. Possover is in Zurich. He cannot come in 2 minutes to New York. So you're alone when you do this surgery. And if you stop the surgery at this point, you will not help the patient, and you will have problem with me if I'm the next surgeon. So, and here you see, we resect all the pelvic muscle, pelvic floor muscle, and that is exactly what you have to expect. When you deal with such kind of endometriosis, you have to know that maybe you will have to do something on the bowel, you will have to do something to the ureter, you will have to do something, whatever. You have to be able to do that by your own, or you have good team able to work with you. So, and with this huge resection of endometriosis, it's exactly the same that I said before. If you don't cut the nerve, if you give the patient the day after the surgery pregabalin, and you send the patient to the physiotherapist, and the best is to advise the patient to use high heels. That is really the best training, postoperative training. The patient will recover. She will recover, but it takes 3 to 5 years. You see, we have a significant improvement in pain, but the patient will recover the motoric function after 3 to 5 years. It's not, I do the surgery, and 6 months later, the patient is happy. The pain are going up to 6, 8 months, and then the pain will start to decrease. It takes really a lot of time to repair after such a kind of thing. That means when you have a suspicion of endometriosis of the sciatic nerve, you cannot give hormone, you have to do something. You have to send the patient to somebody who is able to do this kind of surgery. Don't wait, otherwise we will have problem. And for me, I'm the founding president of the International Society of Neuropelviology, and if I have a message today is learn at least how to do the diagnosis, how to recognize a condition of the pelvic nerve in order to not miss such kind of thing. And you can make the diagnosis with the Eisen. We make an e-learning program online. You go just on our homepage and you will learn how to make the diagnosis. There is an exam in the end, but believe me, the exam is very difficult. To become a neuropelviologist means to learn the neurology and not just the sciatic nerve, the obturator's nerve. You have also to know conditions like spinal cord injury and all these things. And I thank you very, very much once again for the invitation and your patience.